Good morning, everyone. Welcome to the STI clinical update from CAPTC. This is our 2024 summer update and review of syphilis, chlamydia, and gonorrhea with a focus on Northern California and the County of Lake. I'll give it just a few more seconds for folks to join. All right, welcome again, and thank you for joining us today at CAPTC's STI clinical update for the summer of 2024. We're focusing on syphilis, chlamydia, and gonorrhea, and we're doing this with a specific emphasis on Northern California and the County of Lake. My name is Dr. Kelly Johnson. I'm the medical director for the California Prevention Training Center at UCSF. I'll be going over some introductory slides and housekeeping before we get started. First, I'll tell you a little bit about us, the CAPTC at UCSF, which is the University of California, San Francisco. We're a multidisciplinary training and capacity building assistance center. Our STI clinical training, of which this webinar is a part, is sponsored by the CDC, and we're a member of a larger national network of other STD prevention training centers. What do? We provide virtual and in-person training events, technical assistance, clinical tools, and STI consultation services, and we focus on complex STI issues in patient care. To learn more about us or the network of which we're a part, you can visit the websites on this slide. We'll also be putting some links in the chat to a place on our website where you can find some additional clinical resources and tools. I do want to highlight one of our major resources, which is called the STD-CCN, or the STD Clinical Consultation Network. CAPTC runs this for our region, and this is a really neat tool. It's an online clinical consultation network where you can go as a provider, you can submit a complex question about STI patient care that you might have. And one of our faculty, a subject matter expert, will respond to you either by phone or by email, whichever you prefer, and we'll do that within 1 to 5 business days per your request. For today's webinar, here's our financial disclosure. We have nothing to disclose. And here's our CME disclosure, stating that today's training is offered at 2.00 CME units at no cost to you. What do you need to do to earn those 2 CME units? So this is really important. We get a lot of questions about this. So to earn your 2 CME units, you do have to be registered for today's webinar on the NNPTC site by 3 p.m. yesterday. So at this point, please note that registration has closed. Second, you must attend today's webinar live and in full. Attendance is recorded as you sign in, and unfortunately we are unable to provide CME credit if you're just attending part of this webinar or if you're viewing a recording after the fact. Third, you must complete the post-course survey evaluation by a deadline of July 31st, 2024. You'll receive an email with a link to this post-course survey evaluation in an email notification that will come in the next 24 hours. It'll come from this address, training@nnptc.org, and the email will arrive in whatever email address box you use to register for this webinar. Now, to make sure you receive that notification for this evaluation, please do add training@nnptc.org to your safe and trusted senders list, and be sure to check spam and junk folders if you don't see our email in your inbox. Now, if you do meet CME requirements, you'll receive CME notification by August 30th, 2024, and this will come from a different email address. This is us, captc@ucsf.edu, and again, it will go to that same email address that you used to register for today's talk. That notification email will include a link to claim your CME certificate through our CME provider. Again, just to make sure you receive that notification, please do add cptc@ucsf.edu to your safe and trusted senders list. Now, we also get a lot of questions about this. So in terms of slide materials, our slide handouts and a recording of this webinar will be available approximately 2 weeks after today's webinar. This will be emailed to all our registrants. You don't need to do anything to request these materials. They'll just come to you and they'll arrive from that same email, captc@ucsf.edu. Now, I know at this point we're all quite familiar with Zoom and with webinar tools, but for today, just so you know, your microphone, your video, and the chat feature will be turned off, but you can use the Q&A box, and we encourage you to do that. Please type your questions into the Q&A box. We will either answer them by typing back an answer in the Q&A box, or we may decide to answer your questions live during our upcoming Q&A session towards the end of this talk. And now I will briefly introduce our speakers. Here's me. Again, I'm the medical director for the California Prevention Training Center at UCSF. I'm an infectious diseases doctor by training, and I work clinically at UCSF. And I also work as a public health medical officer in STD control for the state of California in the Department of Public Health. We will also have some introductory EPI presentation from Dr. Dewan. Dr. Noemi Mini Dewan is the public health officer of Lake County in rural Northern California. She's also a family physician and currently practices medicine as a hospitalist in addition to her public health work. And last, but certainly not least, we have Dr. Curtis Moore, who is a California Department of Public Health colleague of mine. Dr. Moore is a family medicine trained physician. He graduated in 2022 from Kaiser Permanente's HIV fellowship program. And he joined the California Department of Public Health in STD control in November of 2022. He's also a medical officer there. His work is really interesting and focuses on doxypep, hepatitis B and C screening and outreach, and disseminated gonococcal infections. If you have any questions about CAPTC or about today's webinar, you can reach out to Elizabeth Olson, who's our program manager, and her email address is here. And without further ado, I will turn it over to Dr. Dewan now to go over some brief introductory framing information for today's webinar. Thanks.
Thank you, Dr. Johnson. So greetings, everybody, today. I just want to give a brief introduction into the history of how this event came about. So I am the public health officer of the County of Lake in rural Northern California. I started in this role in September of 2023, and I'm also a practicing physician. So I know what it's like to be on the front lines as you who are listening on this seminar today experience. And I also know the public health perspective. And in public health, we care and focus about entire populations. And to that degree, I can say from the County of Lake that being a rural frontier county, our populations have many health challenges, including in the space of STIs. And when I arrived in my role, we were getting calls from our local providers asking to help the providers in clinics with their strategies for treating syphilis. And because of that, in my role as the health officer, I reached out to CAPTC and found some great resources that actually our public health nurses laminated and handed out to our clinics locally. And wanting to do more than that, I reached out to CAPTC and asked if they could do this training for our providers in Lake County. But then, of course, it seemed like something that would be very important to share with our entire rural northern region. And some of you may be from outside our rural northern region, but we started out with that emphasis of our rural north because we do have some of the similar challenges in the rural north in terms of access to care and access to trainings like this one. So in addition to reaching out to CAPTC, I reached out to the California Department of Public Health and the Regional Public Health Office, RPHO, and the epidemiologist there, Allison Morse. And I'm sharing this with you so that you know that you in the front lines clinics, you have support in your public health departments. And your public health departments can also reach out to our colleagues at academic centers like UCSF and at the state when you come to us asking for help. And in this case, it initiated through help with actual treatment of syphilis from our providers. So next slide, please. So this is a resource that you can actually find yourself online, which are maps from CDPH regarding STI rates in your county. But of course, when you look at this map, you need to know which is your county. If you would like to know beyond your own clinic, what's going on in your entire county. So for Lake County, I've put a little star on the chlamydia map, and then you can follow along from left to right to see what our rates are for these 3 different STIs. And I just wanted to make a point here. If you look at Lake County and you follow it through from left to right, you can see that our gonorrhea and early syphilis rates are high, but our chlamydia rates are relatively low. But as a health officer, I can tell you I don't believe that our chlamydia rates are relatively low. I think what we're doing is not enough testing. So while you're on the front lines taking care of people and treating people, we in public health have to also think about how we can get more access to testing out to our communities. And this is an ongoing challenge for many of us in the rural public health space. So next slide. And I just wanted to call out the resource where these maps came from. All of you, if you would like to learn more about the epidemiology in your counties and general epidemiology of STIs, there are great resources that you can get from the CDPH's STD control branch STI data webpage. And these are live links on this slide, but you can also easily find these if you search online. So next slide. My next slide is just going to be some thank yous. So I want to thank the California Department of Public Health Sexually Transmitted Disease STD Control Branch for helping provide 2021 data. Now, you may have noticed the data is from 2021 in those slides, and that is the nature of epidemiologic data. It is never yesterday's data. I mean, almost never. Usually we have to go back a way to get validated data. So what you just saw was 2021 data. And thank you to Robbie Snyder for providing subject matter expertise. And then also, I just want to call out for the the regional public health office, the rural northern branch, and Erin Noble Delap and the team there for the support that they have provided to help this presentation today. So thank you very much. Thanks for all of the learning you're going to do today. And please know that your public health departments and teams are here to support you all the time. Thank you.
Thanks, Dr. Dewan. Appreciate that framing for this upcoming talk. So now we will be moving into my part of today's talk, which is about syphilis. For some of you, this may be review. If you've heard me talk before, you may have heard some of this exact material before, but for others, this may be very new information. And either way, syphilis is confusing. It can look like a lot of great other diagnoses. The diagnostics are difficult, and it's a great topic to learn and to review. So the learning objectives for this part of our session will be, by the end of this talk, I'm hoping that you'll be able to describe the varied clinical manifestations of primary and secondary syphilis in adults and adolescents, recognize that both treponemal and non-treponemal tests are needed to make a new diagnosis of syphilis in adults and adolescents, appropriately stage and treat syphilis in both pregnant and non-pregnant people, and finally, most difficultly, interpret reverse and traditional syphilis screening algorithms. But we're going to start off with a clinical case, and I do have some questions for you all. So let's say you have a 35-year-old bisexual male who presents to your clinic with genital ulcers. The ulcers are a little bit painful. They're not pruritic, they're not itchy, and there are several of them. The patient's physical exam reveals the following findings. So as you can see, there are multiple erythematous, shallow-based ulcers on the shaft of this penis here. So now, if you can go ahead and launch the first poll, please, I would love to ask you all in the audience, what diagnosis do you suspect? Do you think this is genital herpes, primary syphilis, mpox, chancroid, LGV, or granuloma inguinale? People are voting. I love it. Ooh, we're vying. Herpes versus syphilis. They're very close. I can see the votes coming in. Okay, let's go ahead and end the poll. Okay, so we were looking at about 42% suspecting herpes and 48% suspecting primary syphilis. And then a couple people thinking about mpox. This is all great. All of these things are in the differential for genital ulcerative disease. Now in this case, probably because I'm here to talk about syphilis, the answer was primary syphilis, which will be underlined in a moment. But historically and reasonably, people would have thought that this is herpes due to the fact that there are multiple lesions, they're somewhat painful. But in fact, this was primary syphilis. We tend to think of primary syphilis as being a single ulcer with raised borders, but in fact, we're seeing more and more of cases like this, where folks have multiple lesions that might be somewhat atypical and even somewhat painful. So let's take a step back and just talk about syphilis for a moment. Syphilis is caused by a bacteria, Treponema pallidum, which is a spirochete, which means it has that kind of corkscrew appearance. Its incubation period averages 3 to 4 weeks, but the range is quite long, actually up to 90 days or 3 months. And syphilis is really fascinating because it causes a systemic infection with episodes of active disease, but these periods are interrupted by periods of totally asymptomatic latent infection. Now, transmission most commonly occurs, as you may know, via direct contact to infectious lesions. But of course, transmission can also occur in utero, leading to congenital syphilis, or it can be bloodborne as well. On this slide, and you're going to see this slide several times, but on this slide, you can see an overview of the natural history of syphilis. As I mentioned, this infection is characterized by episodes and stages of active disease, during which time patients will have signs and symptoms of their infection, interrupted by periods of completely asymptomatic or latent infection. Now, serious complications such as neuro and ocular syphilis, as well as in utero transmission of syphilis, can occur at any stage of syphilis. And that's what these arrows at the bottom are meant to highlight for you. But for now, we are going to start on the left-hand side of this slide as we go through our natural history, and we're going to talk about primary syphilis. After exposure, as I mentioned, there's that incubation period of about 3 to 4 weeks before a syphilis ulcer, also known as a chancre, appears. The initial lesion is a papule that appears at the site of exposure, and it then grows and ulcerates over time, ultimately producing the typical chancre of primary syphilis. Now, classically, this ulcer is single, it's painless, it's indurated, there's not a lot of exudate or discharge, and the lesions may have these sort of raised, rubbery borders, which I'll show you in a moment. Patients may also have, in primary syphilis, some regional lymphadenopathy. And importantly, since primary syphilis ulcers are often, but not always, often painless, they can go unrecognized, particularly if they're in spaces like the vagina or the cervix or the anus or the rectum, where patients and providers may not be looking all the time. Now, before I move on from this slide, I do want to point out one really important thing, which is that the chancre of primary syphilis can and does resolve on its own, even if patients do not get treatment. So just something to know. The ulcer appears and goes away, even if patients are not treated. So here's some images. This slide shows an example of the typical ulcer or chancre of primary syphilis. Again, classically, it looks like this. It's single, it's painless, it's a little indurated or firm. It's clean-based, so not a lot of discharge or exudate in the middle of it. And it has these kind of raised, rolled, rubbery edges. And once again, as I mentioned, it would be easy to miss this, particularly if it's in a space where patients and providers may not be looking. Here you see some more images of the typical chancres of syphilis. Single, painless, indurated, raised borders. This is primary syphilis. But syphilis has been called the great masquerader, and it's for a really good reason. As you can see on this slide in particular, the chancres of primary syphilis are not always classic in appearance. They can be multiple, they can be somewhat painful, like what we saw with our case patient. And these sort of atypical appearances may be more common in folks who are immunosuppressed, such as those who have HIV. And you can clearly see here how the images from our patient, or I think these ones in particular on the left-hand side here, these sort of multiple erythematous, shallow-based lesions, these can easily be misconstrued as herpes. And I really don't think for these that it's easily possible to tell apart herpes, syphilis, and even mpox by just looking at them. So my point is, if you see something like this, you should be testing for syphilis and for herpes. And if you have the resources, I'd argue that you should also be testing for mpox if you see, again, something that looks like this. Now, just to round out sort of our differential diagnosis, here's more classic appearance of herpes. These are herpetic lesions as they may appear on a penis. The middle photo shows a pretty classic appearance of herpes. It's classically described for those of you who take boards as a crop of vesicular lesions, often on an erythematous or red base, which I think the crop of lesions in particular is really clear here in this middle photo. And then this image on the right shows how these vesicular herpetic lesions can break open, burst open, and reveal this sort of denuded, ulcerated skin underneath. And then in the later stages of herpes, the herpetic lesions will start to scab over, as you can see on the left here, and eventually they will fall off. Looking at the vulva, this is herpes again. Here you see herpetic lesions where the vesicles have burst open, they've become more confluent, and they've started to sort of grow together. And you can see the skin underneath quite eroded, and this is likely to be painful for the patient. Now, the newer kid on the block is Mpox, which can also cause ulcerative genital disease, just like herpes and just like primary syphilis. This slide shows sort of the classic genital lesions associated with Mpox. They're classically described as being well circumscribed, kind of circular, they're deep-seated, they're palpable, they're firm, you can feel them. And then the real tip-off is that they have this central dot called an umbilication, which you can see on these slides, and which over time sort of starts to scab over, and just like herpes lesions will eventually fall off. But Mpox too can have some pretty atypical appearances, and I just want to show you some slides that were shared with me. I think in particular the middle picture here and the far right picture, these could very easily be confused with primary syphilis. They look very similar. So again, I think it's very appropriate to be thinking about and testing for Mpox, for herpes, and primary syphilis anytime you see a genital ulcer. But getting back to syphilis, I also wanted to remind you that the other thing about primary syphilis is the chancres, they can appear at any sites of inoculation. So it doesn't have to be the genitals or the anus or the rectum, it can be really anywhere. So the lips, the tongue, or the finger are all places where we've seen the lesions of primary syphilis appear. Back to our case. So in this case, after examining those genital ulcers, our provider suspects genital herpes. Not unreasonably, but it turns out he doesn't test for syphilis either. The patient is prescribed acyclovir. The ulcers resolve entirely and he feels totally well. But he returns a few weeks later, this time with a diffuse but subtle non-pruritic rash. I'll show you the picture of the rash on the next slide. So here you see, it's diffuse, subtle, maculopapular rash. Now another question for you all. What do you think is the most likely diagnosis? And I'll ask you to launch the second poll, please. Thank you. So for this diffuse, subtle, maculopapular rash, do you think secondary syphilis, tinea versicolor, Coxsackie virus, atopic dermatitis, contact dermatitis, or pityriasis rosea? Okay, I see a lot of votes coming in. Appreciate all the participation. I'm gonna wait till it slows down. All right, you can go ahead and end the poll, please. Yeah, so we are looking at 94% of folks suspecting secondary syphilis and a few people thinking about atopic dermatitis and contact dermatitis. And I'll say the point here is really not to get this question right or wrong. It's for learning purposes. Now, in this case, you had a huge hint. We are talking about syphilis. You know that our case patient had syphilis. So the answer is secondary syphilis. But the truth is that any of the things that you see on this list can be and have been confused for secondary syphilis. They all cause diffuse rashes. So my point is, if you see a diffuse rash, make sure that secondary syphilis is on your differential diagnosis. Looking back at our natural history slide, I'll remind you again that the chancre of primary syphilis can and does resolve on its own, even in patients like ours who never get treated. Then about 2 to 6 weeks later, the patient will enter the next stage of syphilis, which is known as secondary syphilis. The features of secondary syphilis are what you see in this box, but rash is the most common finding, and it often involves the palms and the soles. Patients may also have sort of a constitutional syndrome, so they may have generalized lymphadenopathy, they may have low-grade fever, malaise, sore throat, headache, as almost like a viral illness of some sort. In addition, there are some unique features of secondary syphilis. They may have oral lesions called mucus patches, or these other lesions called condyloma lata, which look a lot like anal or anogenital warts. I'll show you pictures in a moment, don't worry. Now, secondary syphilis can also come along with a patchy alopecia or hair loss, and that can actually involve both the hair on the head and the eyebrows, interestingly. And patients with secondary syphilis may also develop a subclinical, sort of asymptomatic, often hepatitis. And the most notable feature of this that's sort of unique is like the alkaline phosphatase will tend to be elevated out of proportion to other LFTs that you may check. So that's secondary syphilis. Now back to pictures of secondary syphilis. Here you see the rash. Again, classically, like with our patient, it's diffuse maculopapular rash, and it involves the palms and the soles. But this rash is often missed by providers who don't identify it because it's so subtle and because it can have kind of an atypical appearance. And that's why I put this middle photo here. This really looks sort of old, scarred down. I can see why you might not be thinking about syphilis if you saw this. So this is a place where secondary syphilis can be missed. Even if the rash is very subtle or it doesn't look like what you think it's going to look like, if you see a rash that's diffuse, particularly if it's involving palms and soles, be thinking about secondary syphilis. Bit of an aside, this is a mimicker in the differential diagnosis. This is a patient I saw on the inpatient service. He did not have secondary syphilis at all. He was allergic to vancomycin, but the rash looks very similar. So there you go. In the differential diagnosis for that diffuse rash is also drug rashes. Back to secondary syphilis. These images show examples of these white patches or plaques called mucus patches associated with secondary syphilis. These lesions, just to note, are highly infectious. And they can also be easily confused with other diagnoses that cause white plaques in the mouth, such as thrush or oral hairy leukoplakia. Here you'll see some images of those alternative diagnoses for your differential diagnosis. On the left, you see oropharyngeal candidiasis or thrush. This is classically more diffuse than a mucus patch. And the other thing about it is classically you could take a tongue depressor and you could try to scrape off these lesions. And if it's thrush, the lesion should come off on the tongue depressor. This will not be the case if it's a mucus patch of secondary syphilis. On the right, you see oral hairy leukoplakia. This is an EBV, that's Epstein-Barr virus associated lesion, often seen in immunocompromised folks. Also a white patch in the mouth. Classically, oral hairy leukoplakia has these sort of vertical lines within it. Hard to see in this photo, but what I think you see well is the fact that oral hairy leukoplakia tends to appear on the lateral border of the tongue, so patients may need to stick out their tongue and direct it to one side for you to be able to see these lesions. Here's the patchy alopecia, the hair loss of secondary syphilis. And note that this could easily be confused with alopecia areata, which is a fancy term but means regular hair loss. And again, another place where a syphilis diagnosis could be missed. Here you see these lesions I was speaking about called condyloma lata, and this is a fancy term associated with secondary syphilis for these large, raised, whitish, or gray lesions that are found in warm, moist areas. So often the perineum, the perivulvar area, or around the anus. And like mucus patches, these lesions are very infectious. In terms of mimickers, condyloma lata can easily be confused with anogenital warts. So whenever you see what you think is a condyloma acuminata, an anogenital wart, also be thinking about condyloma lata and secondary syphilis. This is just to compare and contrast, but here you see a condyloma acuminata, an anogenital wart. Whereas the condyloma lata of secondary syphilis were sort of flat on top, the condyloma acuminata, or the wart, is very irregular. This is a pretty extreme case, but very irregular in appearance. It almost has this sort of cauliflower-like appearance. So that may be one way you can distinguish them, but again, be thinking about both. Warts and condyloma lata can look similar. Let's go back to our case again. So after evaluating the patient's rash, the provider suspects contact or allergic dermatitis, which if you don't have this full history of the patient having an ulcer that went away, waiting a few weeks, getting a rash, it's easy to see why this provider might have suspected an allergic or contact dermatitis. The provider prescribes a topical steroid, which the patient uses, rash goes away, and he feels totally well. So going back to our natural history, note that the patient is now in one of those latent or asymptomatic phases of his syphilitic infection. Now, early latent syphilis is when the only evidence of disease is laboratory evidence or a history confirming that the infection occurred within the past 12 months. Otherwise, if you're beyond that 12-month mark, or you have no idea when the infection occurred, then the diagnosis is late latent syphilis or syphilis of unknown duration. This may seem like semantics. You may wonder why I'm even mentioning this, but the distinction actually quite matters because early and late latent syphilis are treated differently, and we'll cover that in a little bit. But first, let's get to the conclusion of our case. So 2 years after the rash has resolved with his steroid treatment, the patient develops new headaches and right eye redness and pain. And the eye symptoms rapidly progress to some visual deficits. The patient goes to the emergency department and he gets a workup that includes a CT of his brain as well as a lumbar puncture. They end up sending a VDRL from his cerebrospinal fluid, or CSF, as part of a meningitis workup. And it turns out that the CSF VDRL is reactive, confirming at last a diagnosis of now neurosyphilis in this patient. Ophthalmology is also consulted and diagnoses ocular syphilis for the eye symptoms. At last, the patient is admitted and started on treatment with IV penicillin. So let's talk now about neuro and ocular syphilis, which our patient has just been diagnosed with. First, remember, as I told you, neurosyphilis can occur at any stage of syphilis. It's a common misconception that neurosyphilis can only occur in late stages of infection, but this is not true. Any stage of syphilis can result in neuroocular or otic syphilis. When neurosyphilis does occur, there are both early and late manifestations. Early manifestations, typically occurring months to years after infection, include cranial nerve dysfunction. And so if you do a cranial nerve exam, you may find abnormalities. It may also include meningitis, so headache, neck stiffness. It may even include stroke or altered mental status. And then there are these late manifestations occurring 10 to 30 years after infection. These are things with fancy names like tabes dorsalis, general paresis. They will present with dementia, psychosis, sort of shooting nerve pains, or even incontinence. These things are very rare, actually, in the antibiotic age. So for you all, I would think primarily about some of those early manifestations of neurosyphilis as what you're most likely to encounter settings. Otosyphilis also occurs syphilitic infection, plus or minus tinnitus or ringing. And interesting because it can affect any eye structure. So there's a whole range that including redness, pain. My point here, really what I want you to take home, is that all patients with syphilis should be assessed for neurologic signs and symptoms. You should ask them about neurosymptoms, you should ask them about hearing and visual complaints, and you should perform a neuro exam in anybody who's diagnosed with syphilis. And if you find any evidence of neurologic involvement, for example, if you find that their cranial nerve exam is abnormal, you should be performing a lumbar puncture. I will point out, it's in small font here, but in the 2021 CDC STI treatment guidelines, they did come out and say that you don't have to get the LP if a patient only has visual or hearing changes. You don't have to get the LP if you're only thinking about ocular or otic syphilis. You still can, it's not wrong, but when you need to get an LP is when you have neurologic complaints or abnormalities on neurologic exam. Back to our case one more time. So while our patient is in the hospital getting his IV penicillin for his neuro and ocular syphilis, one of his female partners delivers an infant at 38 weeks pregnant. The mother, or birthing parent, received no prenatal care. The newborn unfortunately appears ill with copious nasal discharge, hepatosplenomegaly, lymphadenopathy, a rash, and jaundice. They may have looked something like this. The baby also gets a lumbar puncture, and their CSF, or cerebrospinal fluid analysis, also reveals a positive VDRL, confirming a diagnosis of congenital syphilis in this baby. So now we'll go back to our natural of syphilis one more time. And what I want to emphasize, if I haven't already, is that these instances in our case of neuro and ocular syphilis and of congenital syphilis were entirely preventable if our patient had been diagnosed and treated for syphilis at any one of his earlier presentations. And this would have also opened the opportunity for his partners to get tested and treated as well. So at this point, we have reviewed primary, secondary, and latent syphilis, as well as neurosyphilis and ocular syphilis, and we've touched a bit on congenital syphilis. Just to conclude the natural history of syphilis, I wanted to talk just for a moment about tertiary syphilis. This is a potential very late manifestation of syphilis, often occurring years to decades after the initial infection. Tertiary syphilis is very rare, but manifestations can include these things called gummas, G-U-M-M-A-S. These are proliferative, granulomatous, inflammatory processes that made it be really destructive of any affected organs, including the skin, bone, even brain. Tertiary syphilis can also manifest as aortitis or cardiovascular abnormalities, as well as some of those CNS abnormalities, those tabes dorsalis, general paresis, the really, really late neurosyphilis manifestations can also be associated with tertiary syphilis. Again, less common that you would encounter that in clinical practice, but I didn't want to leave it out. What you will likely encounter in clinical practice is the need to diagnose syphilis. So let's talk about syphilis diagnostics. And this is admittedly the most complicated topic that we'll go over in my part of our presentation today. Now, step one, we've already been over. The first step in diagnosing syphilis is just to recognize it in all its different manifestations. And that's why we spent so much time on this topic today. So remember for primary syphilis that the chancres may be multiple, painless, or in locations that you are not expecting. Just be sure to keep syphilis on your differential and to keep your differentials broad. Secondary syphilis can have a variety of manifestations, many of which do look like other diagnoses. So drug rashes, dermatitis, alopecia areata, anogenital warts, thrush, etc. If you see what you think is those diagnoses, make sure you're also thinking again about secondary syphilis. And last but definitely not least, remember that latent syphilis, whether early or late latent syphilis, it's asymptomatic. So the only way you're going to identify patients in latent phases of infection is to screen them for syphilis. Now, another question for you. This is my hardest poll question. And I'll ask you to please launch the third poll in this presentation. Great. So what tests or test are needed to make a new diagnosis of syphilis in an adult? Do you need a treponemal test, like a TPPA or an EIA or CIA? Do you need a non-treponemal test, like an RPR or a VDRL? Or do you need both, one non-trep and at least one treponemal test? Okay, this isn't active. I'm going to let this go for a minute. I see a lot of people still voting. Appreciate the participation. That's great. And we are spread here, actually. I see people voting for all three of our options, which is great. Okay, we're slowing down. You can go ahead and stop the poll, please. Great, so 80-some% of us thought it was answer C, but we were split with some folks also selecting answers A and B. And I think that's totally fair. Syphilis diagnostics, again, are a very confusing topic. For a new syphilis diagnosis, the correct answer was C. You need both a non-treponemal test and at least one treponemal test. So let's dive in now to syphilis diagnostics. Direct detection of the organism T. pallidum from clinical specimens can only be done by dark field microscopy or by polymerase chain reaction. And unfortunately, neither of these tests are widely available. So syphilis diagnostics relies on serologic testing quite heavily, with tests that fall into the two categories that I mentioned, non-treponemal and treponemal tests. And you do need both types of serologic tests to confirm a new syphilis diagnosis in an adult or an adolescent. For non-treponemal tests, examples are an RPR or a VDRL. These are quantitative tests. You get a number, you get a titer, and that allows for an assessment of disease burden, for treatment adequacy, and for reinfection. But they're non-specific. They're detecting something called lipoidal antigens, which can be positive in patients with other conditions that are not syphilis. And then you have treponemal tests on the right-hand side of this slide. Treponemal tests include things like a TPPA and FTA antibodies, an EIA, which is an enzyme immunoassay, or a CIA, which is a chemiluminescent assay. The good news about treponemal tests is they do detect antibodies that are specific to T. pallidum. But the problem is these antibodies usually stay positive for life after initial infection. And the other problem is they're not quantitative, so you can't use them to assess for reinfection or response to treatment. Once somebody has them, they just kind of have them. Most people have them forever. So you use screening algorithms to diagnose syphilis, and there are two different ways that you can screen for syphilis. One is via the traditional screening algorithm, and the other is via the reverse screening algorithm, which is being used a bit more commonly in a number of settings these days. So we'll go through each of these in turn. We're going to start with the traditional algorithm. In the traditional algorithm, you start with an RPR. If the RPR is negative or non-reactive, that's it, testing stops, you are done, the patient is not diagnosed with syphilis. But if the RPR is positive or reactive, the test should reflex to a treponemal test, usually a TPPA. If the TPPA is negative or non-reactive, then syphilis is generally unlikely, and that RPR that you saw is probably a false positive. On the other hand, if the TPPA is reactive, and you've got already your reactive RPR, the patient has either past or present syphilis. The patient's clinical and testing history then need to be used to determine whether we're looking at an old treated infection, an old untreated infection, or possibly a new infection that's just being uncovered. Information that you need to make these determinations include the following. So you need to ask about symptoms of primary or secondary syphilis. You need to know about any prior syphilis diagnosis and treatment history, and you need to know non-treponemal titers, like RPR titers, with a 4-fold change being considered clinically significant. And we'll talk more about titers in a little bit. Just to make this even more complicated, there are a few caveats that I wanted to just mention. Going back up to the very top of this algorithm, if your RPR is non-reactive, but you have very high suspicion, for example, if you see what you think is a chancre of primary syphilis, you should still treat presumptively, even if the RPR is non-reactive, based on clinical suspicion alone, because it takes a little while for the RPR to turn reactive. One other caveat, which is if you're in the situation of discordant results, RPR reactive but TPPA non-reactive, syphilis is unlikely. But if the person is pregnant, or if you think there's somebody who is very vulnerable to syphilis, I would suggest rescreening in 2 to 4 weeks just to make sure you weren't missing an early case. So that's it for my caveats. That is the traditional algorithm. For the reverse screening algorithm, you start with a treponemal test. Usually it's an EIA or a CIA. Here, if that's negative, you're done. Testing stops, the patient's not diagnosed with syphilis. On the other hand, if that EIA or CIA is positive or reactive, a standard RPR is performed next. If the RPR is reactive, you now have 2 positive syphilis tests, and the patient is diagnosed with past or present syphilis, just like with our traditional screening algorithm. You'll still need the clinical history and any prior available RPR titers to determine whether this is an old or this is a new syphilis infection, as well as to figure out which stage of syphilis you're in. But you know at that point the patient has either past or present syphilis. On the other hand, if you're in the situation where EIA is reactive, but the RPR is non-reactive, a second treponemal test needs to be done. It's usually a TPPA, and it's done as sort of a tiebreaker. If the TPPA is negative, syphilis is generally unlikely. And if it's positive, the patient again is diagnosed with past or present syphilis, and management has to depend on the clinical scenario. So for example, if the patient has a known history of treated syphilis and has no new exposures, and you have a reactive EIA and a reactive TPPA, that very well may just be an old treated infection, nothing to do. Otherwise, patients who don't have a history of treated syphilis, but do have 2 positive treponemal tests, a reactive EIA and a reactive TPPA, you do need to treat them. And unless you can prove that the infection occurred within the last 12 months, you treat them for syphilis of late latent or unknown duration. Now, I know that this is complicated, and I am not expecting that you've memorized this all. So actually, my main takeaway around syphilis screening algorithms is that I want to draw attention to this resource from CAPTC that you might find helpful. This is a document that presents the 2 different syphilis screening algorithms, then goes into detail about how to interpret different combinations of serologic test results. It also includes recommended actions for what a clinician may want to do, depending on which combination of serologies they get for their patients. So I highly recommend that resource. I think it's very helpful. Now, we talked a little bit about titers for non-treponemal tests like RPRs. So far, what we've been talking about is how to make a new diagnosis of syphilis. You need both an RPR and a treponemal test, at least one. But what about people who already have a known history of syphilis? Remember that treponemal tests like the TPPA, the FTA antibodies, the EIAs, these can stay positive for life. So they become unhelpful in folks who you know have had syphilis and already been treated. In those patients, you have to rely on the non-treponemal titers, the RPR and VDRL titers by themselves to monitor for treatment response and reinfection. So with RPR and VDRL titers, higher numbers correspond to a higher level of antibodies in the patient's serum. Now, a 2-fold change, and what I mean by that is if you went, say, from 1 to 16 to 1 to 32, that's a 2-fold change because 16 times 2 is 32. A 2-fold change like that is generally considered within the margin of error of the test, nothing to do. But if you see a 4-fold change, for example, 1 to 2 going to 1 to 8, 2 times 4 is 8, that's a 4-fold change. And if that is sustained for at least 2 weeks, that is considered clinically significant. So if you see a 4-fold rise in titers, that would mean the person had a new infection. You do want to compare titers using the same serologic test. RPRs tend to run a bit higher than VDRLs, so you can't compare RPR to VDRL titers directly. So if at all possible, try to keep running the same non-treponemal test in your patients for monitoring purposes. What about diagnosing neurosyphilis? So again, in syphilis patients with neurologic signs and symptoms, you do want to perform a lumbar puncture. And the main parameters of interest include the cell count, the protein, and a CSF VDRL. If you've got a reactive CSF VDRL, that is diagnostic. The patient has neurosyphilis. If you don't have a non-reactive VDRL, but you've got an abnormal white count, an elevated white count in the CSF, plus protein if it's very high, those features, the white count and the protein, can support a neurosyphilis diagnosis in the right context, again, even if the VDRL in the CSF is non-reactive. If you're in that scenario and the VDRL in the CSF is non-reactive, but your suspicion is very high, what you may want to do is add a CSF FTA antibodies if you can. This is less specific but very sensitive. And again, if clinical suspicion is very high, you may just want to go ahead and start empiric treatment while you wait for that FTA antibody to come back. Patients who have a suspected ocular syphilis should be immediately referred to and managed in collaboration with an ophthalmologist. And I do want to point out that if you get an LP, that actually doesn't rule out a diagnosis of ocular syphilis in the right context. So if a patient just has a red, painful eye and you decide to do a lumbar puncture anyways, even if the LP results are normal, you do need to involve an ophthalmologist and you do still need to be thinking about ocular syphilis. Now, on to syphilis staging and treatment. Obviously, once you've diagnosed syphilis using our algorithms, you'll need to make sure that you treat your patients properly. And proper treatment does rely on making sure you know what stage of syphilis the patient is in. So this is a nice graphic. Early syphilis, which includes primary, secondary, and early latent syphilitic infections, these are all treated the same. They only require a one-time dose of IM benzathine penicillin, also known as bicillin LA. On the other hand, syphilis of late latent or unknown duration requires 3 weekly doses of bicillin, ideally given 7 days apart and again given intramuscularly. There are alternative treatments for non-pregnant folks, heavily relying on doxycycline. So for early syphilis, doxycycline for 14 days is an alternative option. And for late syphilis, doxycycline for 28 days is your alternative option. I really want to highlight what's in red here. Please do not use bicillin CR. This is a confusing topic, but bicillin CR, it's a mix of short and long-acting penicillins. It is not the same as bicillin LA, and it is not adequate treatment for syphilis. So do not use bicillin CR, use bicillin LA. A couple more notes on treatment. So in pregnancy, forget about doxycycline. Penicillin is the only option for treatment for syphilis in pregnancy. You need to treat with a penicillin regimen appropriate for the stage of infection. And pregnant people who are allergic to penicillin need to be desensitized and still treated with penicillin. Now, all patients with syphilis should be tested for HIV. I'm going to pause myself for 1 second. Apologies, my computer's. All right, very sorry about that. Okay, where were we? Penicillin in pregnancy, only option. Now, for neuroocular and otic syphilis, your option is IV penicillin. It's called aqueous crystalline penicillin G. It's given IV, as I mentioned. It's given for 10 to 14 days. If you look in the guidelines, you will see this alternative option involving procaine penicillin. Procaine penicillin is no longer available, so this is not a practical option, and we are really focusing on the IV aqueous crystalline penicillin G. Now, the last point that I want to make about treatment is the importance of performing a day of treatment RPR titer. Performing a day of treatment titer establishes a baseline to compare response after treatment. This is a frequently forgotten component of syphilis management, but it's really important because without a true baseline documented, it becomes really hard to assess response to treatment. So imagine you have a patient in this scenario. They come in, they're diagnosed with syphilis, their RPR is 1 to 256. They don't get treated that day, they come back next week and they just get treated. If you don't know that their titer on that day is really high, it's really hard to interpret their follow-up titers. Let's say this person comes back 3 months later, they've been treated, and their RPR is 1 to 256. again, if you didn't know that the peak was so much higher, you might be thinking, what happened? Did this person fail treatment? Did they get reinfection? Do I need to retreat? But you could have avoided this whole scenario. All you need to do is check an RPR on the day of treatment. Okay, last, I do want to share several resources available to you to help with syphilis. Of course, you can always contact your local health department for assistance if you need to know about prior syphilis tests or confirm whether adequate treatment was received. The state is also a resource for that. And our health departments can, of course, help with other aspects of syphilis management, like partner notification or treatment access. And here at California Prevention Training Center at UCSF, I again just want to mention STD-CCN. This is a great resource. You can go to this website, enter your questions, and we will answer them in 1 to 5 business days. Okay, so quick conclusions for my part of this talk. So these are the take-homes that I would love for you to remember. Syphilis presents differently in different stages of disease, and it can be easily misdiagnosed. If left untreated, patients will progress through those stages of active disease interspersed by periods of totally latent or, again, asymptomatic disease. Now, the outcomes of untreated primary, secondary, and latent syphilis can be severe. They can involve neuroocular otic syphilis and even congenital syphilis, and that can be fatal. I also want to emphasize again that those serious complications of neuroocular otic syphilis and in utero transmission can occur at any stage of syphilitic infection. I also want to remind you that a new diagnosis of syphilis in adults and adolescents involves both treponemal and non-treponemal tests, and that syphilis is treated differently depending on the stage of disease. But remember, penicillin is the drug of choice and the only option in pregnancy. Finally, most importantly, perhaps, remember to include syphilis on your differential diagnoses and to be screening broadly. With that, I'd like to acknowledge a number of folks on this slide who contributed thoughts or ideas or concepts for this talk or images. I want to thank all of you for being part of this audience. I want to thank Dr. Dewan for reaching out to us to set this up. And in my last just couple of minutes here, I won't go over this in detail, but I want to let you know that at the end of my slides, which you will receive after this webinar, there are resources for syphilis screening. These are the resources from the CDC with regards to how often you should be screening your patients for syphilis, and it varies by population. I won't go through all of these in detail. I just want you to know that this resource exists and that there is a link at the bottom of the slide for you to visit when you're seeing your patients and thinking about who to screen and how often to screen. I also want to point out that the state of California does have expanded syphilis screening guidelines, which were issued in 2020, which are linked on this slide. These are focused on diagnosing and treating syphilis in people who are or could become pregnant. And they're a little bit different from the CDC. So again, you'll have this resource and you'll have this link. I do expect that these syphilis screening guidelines may be further expanded in California in the coming months. So be on the lookout for that as a little bit of a teaser. Here are references. I'm going to stop and I will answer questions in the Q&A. We may do some of them live at the end. I'm going to turn it over to my colleague, Dr. Curtis Moore, to talk about gonorrhea and chlamydia next. Thank you all.
Thanks, Kelly. That was excellent. All right, let me try to share my screen. All right, here we go. I said I could do it before. All right, hopefully folks are seeing my screen. All right, again, name's Curtis Moore. I use the pronouns he and him, and I work for the California Department of Public Health and the STD Control Branch. A lot of these slides are also thanks to a lot of my colleagues out there, so I don't have an acknowledgement slide, but I want to say they are a lot of my colleagues out in the department, and so thank you and shout out to those folks. All right, learning objectives here, and so we're going to recognize the sequelae of sexually transmitted, let's see, the pointer, chlamydia and instances of PID or pelvic inflammatory disease, also sexually transmitted gonorrhea, looking at DGI or disseminated gonococcal infections, and antibiotic resistant gonorrhea itself, and then also kind of go over recommended treatments as well. First, we're going to figure out how common are these pathogens and where. We want to start with chlamydia in orange here. It is the most commonly reportable STI in the state of California. And you'll see in the following slides, the rates decreased due to COVID, but likely due to decreased screening rather than decreased rates. And then since then, some increasing there. And interestingly, the highest rates are in young females. When it comes to gonorrhea, it's the second most reported STI. Rates are continuing to increase in the state of California. And here the highest rates are in males. Now, this is a slide from CDPH. Again, as Dr. Doohan pointed out, we only have epi data up through 2021. But you can see the orange line at the top is for chlamydia. Of course, that dip in 2020 for COVID, and then starting in 2002, and then increasing right around the 2012 mark for gonorrhea in this aquamarine color. And then, of course, what Kelly went over with syphilis increasing as well. These slides were also shown by Dr. Doohan, so thank you for that. And you can see number of cases for the state of California is on the left, and then chlamydia rates on the right. Orange, I'm trying to keep the colors here for orange for chlamydia. And you can see what Dr. Doohan said, that rates and cases seem to be low here with data, but may not actually be representative of County of Lake. When it comes to chlamydia and age group and gender, on the left and the darker orange is males, on the right is for females. We'll notice in the center, it's the young females and young males, and generally the young population that have higher rates of chlamydia. When we break it down to race, ethnicity, and gender, again, on the left, males, on the right, females, we'll notice some disparities among the Black population there. And that can all be related to social determinants of health, access, resources, and things of that nature. Moving on to chlamydia, you can see on the left, these are the number of cases. And so County of Lake here, kind of along the middle here, what you can notice is as rates, definitely in the higher number range for gonorrhea there. Again, dividing by age group and gender, on the left, males, on the right, females. We tend to see the younger population as well, ages in the 20 to 34 range. Among race and ethnicity, males on the left, females on the right. Again, disparities among the Black population there. These are the resources that Dr. Doohan also referred to. This is on our website, a lot more demographics, epi data that's available, and you can explore that as you would like. Now, taking a step back a little bit, 101, STI 101, how do these pathogens infect tissues and cause disease? We'll start first with chlamydia here. I think what's very interesting about chlamydia is we have these little particles called the elementary body. These are the infectious particles, but non-replicating. They infect into the epithelial columnar cells, or sometimes the white blood cells, and they create this inclusion. And then they transform into what's called a reticulate body. This is the non-infectious but replicating form of chlamydia. And as you can see, as it progresses over time, more reticulate bodies are formed. Some are reorganized back into the infectious elementary body. And then you have rupture occurring in 48 to 72 hours to then continue on infecting other cells. For gonorrhea, gonorrhea attaches to different types of epithelial cells, have these little structures on the outside, sometimes called the OPA proteins. And then, of course, they infect different types of mucosal surfaces, urogenital epithelium, the oral pharyngeal tract or your throat, and of course, conjunctival tissue as well. It evades our immune system by certain proteins, also by creating a biofilm that kind of encapsulates itself and protects it from our immune system. Where are these epithelial cells? Well, it's kind of, as mentioned, you can kind of have the throat, oral pharyngeal, cervical tissue, of course, urethral tissue, and then intra-abdominal as well. Now, who do we screen for chlamydia and gonorrhea? These are CDC guidelines here. I took pretty much chlamydia and I added some gonorrhea stuff as well. Like syphilis, it is divided by population, so you can kind of read through these. But generally in women, it's the younger population, those that are increased at risk if they're older, retesting for those sexually active persons at 3 months. And then rectal chlamydia testing can be considered based on sexual behaviors and exposures. And then pharyngeal rectal gonorrhea can also be considered as well. In pregnant women, again, younger individuals, a little bit older individuals at increased risk, you're retesting during the 3rd trimester. But noting specifically in pregnant women or persons who can become pregnant, a test of cure if someone is treated, and then retesting in 3 months to make sure the infection has resolved. But there's no test of cure for gonorrhea if treated. For men who have sex with women, not a lot of evidence for screening in the heterosexual population that are at low risk, but may be considered in young men who are in high prevalence clinical settings. For gonorrhea, that is insufficient evidence for screening, even in high prevalence clinical settings. However, for men who have sex with men, at least annually, and sexually active men who have sex with men, and that's at sites of contact, so urethra, rectum. And then you can add pharyngeal testing for gonorrhea in men who have sex with men. And then maybe more frequent testing every 3 to 6 months for those that are at increased risk. For example, people that are men who have sex with men on HIV pre-exposure prophylaxis, maybe with HIV, or having multiple sex partners. When it comes to transgender and gender diverse folks, a screening is based on anatomy and then based on sexual risk and exposures there. You can consider rectal site, again, based on sexual behaviors and exposure risk, and then oral pharyngeal testing for gonorrhea. For persons with HIV, all sexually active individuals, you're screening them at the first visit for gonorrhea and chlamydia, and then at least annually thereafter, and then maybe more frequent screening depending on risk factors and exposures. Now, I mentioned a couple different folks and populations getting 3-site testing for chlamydia and gonorrhea. 3-site testing is based on exposed anatomical sites, so the urogenital or urine tests, the oral pharyngeal or throat, and then anal rectal area. In studies among men who have sex with men, it turns out that if they were diagnosed with rectal chlamydia or gonorrhea, they did not have any urethral infection. So if you only are doing urine-only testing for chlamydia and gonorrhea, you might miss 70 to 88% of chlamydia gonorrhea infections. So definitely 3-site testing for those populations. Additionally, for rectal gonorrhea, 85% of infections are asymptomatic. So if you're not screening, you're not going to find it. Good thing is specimens can be self-collected by the patients. There's lots of diagrams out there educating patients how to do that, or it can be provider collected as well. As far as CDPH recommendations for 3-site testing, we recommend all sexually active persons living with HIV, regardless of gender, at least annually for all exposed sites. Then HIV negative men who have sex with men that are not using HIV PrEP, at least annually at all exposed sites. Folks that might be at higher risk, men who have sex with men using HIV PrEP, quarterly STI screening at exposed sites, and then the transgender, gender diverse based on anatomy, and then their sexual behaviors or exposures. Now, a little caveat here, and this little asterisk in red, testing for oral pharyngeal or chlamydia of the throat is not routinely recommended, but a lot of the tests that we use are combination tests automatically. And so we tend to get chlamydia and gonorrhea when we are doing throat testing. The example I haven't noticed in clinic is the Aptima test that is testing both, even though it's not routinely recommended. Now, how do symptomatic chlamydia and gonorrhea infections present? And as far as natural history, we can have urethritis, cervicitis, epididymitis, or architis. And this is basic anatomy on the left for male anatomy, and then you have female anatomy on the right. In general, urethritis and cervicitis, we have presentations of urethral inflammation, cervical friability. Of course, chlamydia can be a cause, gonorrhea can be a cause, and then some other known STIs, mycoplasma genitalium or MGen, and then trichomonas vaginalis or T. vaginalis. Other signs and symptoms, some burning with urination, some itching at the urethral meatus, definitely some discharge that can happen. For females, you might have some irregular bleeding or maybe postcoital bleeding, and then painful intercourse can happen as well. If you're at a site where you can do microscopy and you're looking under a microscope and you're not seeing the gonorrhea there, and you are ruling that out, but the organism's still unknown. Sometimes we call this non-gonococcal urethritis. Most cases, we do find that it is chlamydia. Testing in-house could be that point of care testing. So that's in-house lab with that microscopy or a centrifuge. And so under microscopy, you're doing discharge staining and looking for white blood cells, or you're spinning down the urine looking for the leukocyte esterase or the white blood cells as well. But most of us don't have that readily available. So we're doing the nucleic acid amplification tests, either from swabs or urine. I'll touch base on that in a few slides forward. Just for a differential, when folks are presenting with discharge, so vaginal discharge, multiple organisms can be responsible here on the right. And then on the left is this table kind of determining in the first column you have symptoms, the type of discharge, the pH, odor, maybe findings on physical examination, or then using microscopy. And across the top, we got bacterial vaginosis, yeast or candida, trichomonas, and then of course gonorrhea, chlamydia, and then physiologic discharge can also be a factor too. And just for reference, when diagnosing bacterial vaginosis or BV, this is the AMSL criteria that you can use. Now working our way up the GU tract, up the epididymis, up the urethra into the epididymis, this is where you have epididymitis. So on the right diagram, some inflammation of the epididymitis. And then you can also have orchitis, the testicle is involved. Typically, you might find both are involved, and that's epididymo-orchitis. Generally, it's a clinical syndrome, acutely less than 6 weeks, can present with pain, usually unilateral. You might have some swelling, even palpable swelling, as in like a hydrocele, and of course, tenderness, either of the epididymis or tenderness of the testicle itself. Can lead to decreased fertility. Some develop chronic pain, even following treatment. And of course, keeping in mind ruling out testicular torsion as a possibility for that pain. Some sexually transmitted infection causes, of course, based on this talk. We got some chlamydia, gonorrhea, and other STI, MGen or mycoplasma. And then thinking for men who have sex with men that practice insert of anal sex, thinking enteric organisms like E. coli. Moving on to prostate. So there has been studies of chlamydial prostatitis happening, acutely presenting fevers and chills, scroll pain and then swelling again, pain after sex, painful urination. Lower back pain could be a clue as well. Even after treatment, some folks might have chronic pain or chronic prostatitis. You also, if you had ruled out chlamydia infection or treated, maybe considering testing for these other STIs like MGen or trichomonas. There is some controversy with this, however, because when you're obtaining samples, you might have some urethral contamination. That's where the chlamydia is versus in the prostate, even with a prostatic biopsy. You might have some urethral material from that. And so some studies suggest that maybe it's not chlamydia itself that's causing it, but keep it on your differential and think about chlamydial prostatitis. Now, coming back to that question of the swab and the urine, definitely the best way is using those nucleic acid amplification testing for these specimens. For penile infections, it's okay to use a first catch urine. Either self-collected meatal swabs have been found comparable to the patient-collected urine sample or provider-collected urethral swabs. So using a first catch urine, is the best and easiest and can be provided and is comparable. However, for vaginal swabs, when the vagina is present, urine might miss in the bottom point here. The urine might, the nucleic acid amplification test might miss about 10% of chlamydial infections compared to a genital swab. And so vaginal swabs are preferred, and they can be collected by the clinician or the patient. And studies have shown equivalency in sensitivity and specificity for both the patient and the provider collection. Now, what about infections of the gynecological reproductive tract and the rectum? That'll jump us into a case. And so here we have a 32-year-old man who has sex with men, presents with rectal discharge, tenesmus for about 2 weeks. He reports condomless receptive anal intercourse with multiple sexual partners. And on exam, you see perianal ulceration. So on the right, you can see some ulcerations here. Hemorrhoid-like masses, so kind of in the maybe 1, 2 o'clock position here. And then on endoscopy, you note bloody and purulent discharge. And so here we'll have our poll. There you go. I see it popped up. Now, I'm not seeing any responses, so I'm just assuming folks are responding. We'll give it 10 more seconds. 9, 8, 7, 6, 5, 4, 3, 2, 1. Perfect. Let's see what we got. All right, I am seeing some syphilis, about 16% syphilis, 31% gonorrhea, and then majority of folks at 43% some combination. And that is excellent. Definitely you want to be thinking about all these different types. Certainly a syndemic approach, because one doesn't happen by itself. Usually there's some sort of combination. But now you're in the office, you may not have these tests right away. So what are we gonna do with this patient now? We're gonna presumptively treat them for proctitis or proctocolitis before they leave the office. So that's ceftriaxone, 500 milligrams. Now this is an increased dose from the 250 milligrams that's recommended in the 2015 CDC treatment guidelines for gonorrhea. And this is now the 2021 recommendation. So ceftriaxone, 500 milligrams. We're gonna add on some doxycycline here in light blue, and then acyclovir for that clinical suspicion of herpes simplex virus. And then next slide here. Here are our lab results. You can see for all the testing done for gonorrhea and chlamydia, so 3-point testing, rectal chlamydia was positive. Herpes, HCV, herpes simplex virus, was negative. Syphilis, again, both tests, as Kelly pointed out, were negative. HIV was negative, and Mpox was negative. Now, of course, this is definitely reasonable for syphilis. This could have been that condyloma lata that Kelly mentioned. Of course, Mpox or HCV, ulcerative disease looking there. But what we have here is a certain type of chlamydial infection called lymphogranuloma venereum, or LGV. It's caused by a specific type of chlamydia or serobars, L1, L2, and L3. As far as US prevalence, about 1% in men who have sex with men. It can represent 6 to 30% of rectal chlamydial infections. It is oftentimes associated with other things like HIV and hepatitis C virus. If the associated group are chemsex, folks have a history of syphilis. And notably, 75% of LGV cases are symptomatic, so we do have that rectal pain and discharge out. But 75% of non-LGV rectal chlamydia are asymptomatic. A general approach we can think when someone has positive rectal chlamydial test is starting at the top. If you have symptoms on our patient, the patient experienced symptoms, so yes. Do they have risk factors for LGV? So receptive anal intercourse, multiple partners, we say yes. And so treat for LGV. That would be doxycycline 21 days worth. We are sending out the sample to be tested for those serobars, which does require a certain molecular testing. If you're using an alternative treatment that's not doxycycline, then you consider doing a test kit. But if the patient is given doxycycline, Test of care is not necessarily recommended. Now, the patient did not have risk factors. They had symptoms, but no risk factors. But they had other, they had symptoms, no risk factors, but were developing severe symptoms. You could empirically treat for LGV. An alternative would be following the little arrow over here where you treat for non-LGV, giving them doxy times 7 days, but you might send off for LGV testing. And if it comes back within 7 days, you then can extend the treatment to 21 days. Now, for persons with rectal CT, say someone just coming to the office for screening and they have no symptoms, then you're just treating them with 7 days of doxycycline for chlamydia. Now, getting a little bit more complicated as far as gonorrhea and chlamydia infections, we have something called pelvic inflammatory disease. It presents with pelvic pain in the upper gynecological tract, sometimes lower abdominal pain, but it's typically a spectrum of inflammation, and we can have any combination of these issues up here in these kind of green boxes. So you have endometritis, salpingitis, abscess, pelvic peritonitis, bladder infection, all sorts of things in here, and it's very broad. Things to help with the diagnosis, of course, if someone's presenting with a fever, so an elevated temperature, they are on physical exam having cervical discharge or cervical friability. Maybe you're able to evaluate white blood cells under microscopy. Again, it's an inflammatory response, and so if you're able to get quick markers, maybe in an emergency department, you might find the SED rate elevated, you might find the elevated CRP. And of course, if the person does have cervical gonorrhea or chlamydia infection, it might boost your suspicion for pelvic inflammatory disease. In most cases, it is
Dr. Moore, it's Kelly. I'm so sorry to jump in. I think there may be a bit of an issue with sound quality going on. I wonder if you're able to change anything about your microphone or speaker setup.
Oh goodness. I don't know. I could try putting my AirPods in, but those were not connecting very well last time I tried using them.
I think even just right now that you're a little bit closer to the screen,
Okay.
it actually
Yeah, maybe I
sounds
was getting
good
bad.
to me. Yeah, so maybe try that for now.
Okay, great.
Sorry.
No worries. Getting back to pelvic inflammatory disease, 50% of the time we do see gonorrhea and chlamydia, but that means 50% of the time or half it's something else. Might be vaginal flora, so think of the anaerobes, H. flu, some enteric gram-negative rods, strep, maybe even some of those other STIs, T. vaginalis, uroplasma, MGen again, even CMV has been reported. And because of something else, treatment needs to be a broad spectrum, which I'll touch base with in a bit. An important thing about PID is if, say, a patient's coming into the office, maybe just lower abdominal pain, you may not even be thinking of STIs if you're not thinking of a sexual history. CDC does have a 5Ps model, and that's where they talk about partners, practices, protection, past STI history, pregnancy prevention. The Fenway sexual history with sexual and gender minority individuals adds on to the 5P model and then includes preferences, pleasure, and partner violence. And of course, CAPTC does have a webinar about sexual history. So taking a good sexual history can help focus your differential of PID. We are presumptively treating PID in younger individuals, especially at risk for that STI, and which you would know by taking a great sexual history. If they're experiencing that pelvic or lower abdominal pain, and then having any other of these. So if there's no other identifiable cause for illness, then presumptively treat, and particularly on physical exam, they're experiencing cervical motion tenderness, uterine tenderness, adnexal tenderness, then you might have very high suspicion of PID and presumptively treat. This is the slide where it reviews what type of antibiotics and antimicrobials to use. Very busy here. I don't expect you to memorize it. The important thing is checking resources because there can be updates as years go on. So looking at the pelvic inflammatory disease STI treatment guidelines through CDC is the better recommendation. But to put out here on the left, treatment can be parenteral or through IV. You can see it includes ceftriaxone or cephalosporin in red. adding on in light blue doxycycline, and then maybe a third agent of metronidazole, again, broad spectrum antibiotics. There are some alternatives that I have here in purple, a little bit more complicated, so I didn't put all the numbers there. And then, of course, oral can also be used, or IM, again, using a cephalosporin in red, again, adding on doxycycline in light blue, and for orals, having metronidazole in green, and in one case is adds on probenecid. Again, alternatives here at the bottom, a little bit more complex, but always check resources to make sure dosaging, amount is all correct. Now, a common question is, well, doctor, what do we do when someone has an IUD or an intrauterine device? The risk tends to be within the first 3 weeks after insertion of PID. But if someone is diagnosed with pelvic inflammatory disease and they have an IUD, the IUD does not necessarily need to be removed. Now, the caveat to that is if treatment with antimicrobials is started and there's no clinical improvement within the first 2 to 3 days or 48 to 72 hours, you can consider removing the IUD going forward. Now, what about disseminated gonococcal infections, or DGI? This is where gonorrhea invades the bloodstream and it spreads to distant sites of the body. Patients tend to present feverish, have skin lesions, like these little pustulous or petechial skin lesions on the extremities, can have polyarthralgias or septic arthritis. They present with a swollen red joint like the knee. And then it can be even more complicated where it settles into the heart and they have endocarditis, settles in the brain, meningitis, or even goes into the bone, osteomyelitis. DGI is frequently misdiagnosed, particularly if someone is presenting with septic arthritis, they're a young individual, their knee hurts, they might say, oh, I twisted it or I did something, and then it's missed. So definitely keeping DGI on your differential, especially doing a sexual history, finding out someone's sexually active, can increase your threshold and suspicion for DGI. The most common presentation we have of DGI is arthritis and arthritis dermatitis syndrome. On the right in these pictures, you can see little type of lesions, kind of vesicular, maybe a little flat, erythematous in one. And then combined with joint pain, the recommended treatment is ceftriaxone given IM or IV every 24 hours. There are some alternative regimens with cephalosporins. But you can switch to orals after 24 to 48 hours if the patient is improving substantially. You can use antimicrobial susceptibility testing to guide treatment. So say cultures are sent off, positive for gonorrhea, and susceptibility saying that it's susceptible to Cipro. You treat orals with Cipro. Or empirically using cefixime 800 milligrams twice a day. The main thing is to recognize is that treatment course at least 7 days of that cephalosporin. And if chlamydia has not been ruled out, make sure that patient is being treated or tested for chlamydia. Now, the other DGI conditions, one's a little bit more serious here in blue, in the brain, meningitis, 10 to 14 days, endocarditis, at least 4 weeks, and that septic joint, at least 7 days, or that 1 week, possibly longer, depending if joint aspiration or surgical debridement is involved. But interestingly enough, the duration of DGI has not been systemically studied. You definitely want to treat empirically or based on clinical or based on the antimicrobial susceptibility testing or getting ID consult as well to help guide therapy, particularly in the hospital setting. Remember, exclude chlamydia or treat, offer the patient partner services within the last 60 days, treating presumptively with the cefixime, and maybe even offering doxy-PEP, HIV PrEP, and then preventative vaccines as well to be comprehensive. As far as making the diagnosis for DGI, we have specimen collections at the mucosal site. That's a 3-site testing, so the urogenital or urine, the throat, pharyngeal, and the rectal, and that's by nucleic acid amplification testing, and also culture if available, if you are able to get that. To get a disseminated site, this is getting a culture either at the skin from a skin lesion, either from aspirated synovial fluid off a knee, or blood cultures, or if you end up doing a lumbar puncture, the CSF culture from that. This is more for surveillance, what case definitions are. And so noticing that a verified DGI case is when we are actually isolating gonorrhea from a disseminated site by culture or nucleic acid amplification testing. And that disseminated site, of course, is a skin lesion, synovial fluid, blood, or CSF. It's likely to be DGI if the patient is presenting with clinical manifestations. So say they're having like a septic joint, fevers, chills, positive sexual history, and you are able to isolate gonorrhea from a mucosal site, typically by culture or NAT, and that mucosal site being your genital, rectal, or pharyngeal. So that would be likely, so that's not having any sort of disseminated site laboratory confirmation. And then suspect that if there's no other likely diagnosis, the patient is presenting with DGI, but unable to confirm with laboratory testing. Now we're going to get to treatment. For chlamydia, these are the changes from 2015 to 2021. STI treatment guidelines for CDC. Recommended here at the top in bold is doxycycline. So no longer using azithromycin, although it is an alternative treatment, but the recommended preferred is doxycycline, 100 milligrams twice daily for 7 days. And then during pregnancy, the recommended regimen is azithromycin, 1 gram as a single dose. Some alternative regimens here, then keeping in mind in pregnancy, we are doing a test of cure 3 to 4 weeks after treatment. And the reason for doxycycline over azithromycin is through several different studies, and these are the authors of those different studies. We have azithromycin in the dark kind of fuchsia pink. It's only getting into like the upper 80s, low 90s, maybe low mid 90s. Doxycycline efficacy is in the upper 90s. It's even more stark for rectal chlamydial infections, looking at the efficacy of, again, doxycycline versus azithromycin, where the light pink is the doxycycline, which reaches into the 100% upper 90s, but azithromycin tends to be a little bit on the lower side, 83% down to 79%, maybe low 90 up here, but much lower efficacy than doxycycline. So doxycycline is the preferred regimen over azithromycin. Now with gonorrhea, it's a little bit more complicated because there's a lot of resistance out there that there's concerns for. And you can see in between 2009 and 2019, this is from the gonococcal isolate surveillance project, where they, in certain settings, are checking susceptibility. So in 2009, in this green section, so 3/4 are susceptible, but 1/4 of gonorrhea isolates were had reduced susceptibility or resistance to these antibiotics listed on the side. Fast forward to 2019, we're now less than 50%. We're more than 50%, or just over 50%. You see reduced susceptibility or resistance of antibiotics for gonorrhea. We determined reduced resistance by, there we go. Reduced resistance is determined by minimum inhibitory concentrations, and these are from the Clinical and Laboratory Standards Institute. This is in relation to ceftriaxone, so that is the treatment of choice for gonorrhea. And so susceptibility is labeled at the 0.25 for ceftriaxone. It is an alert for cefixime for reduced susceptibility. But for ceftriaxone, we have an alert set for surveillance purposes at 0.125. And then unsuccessful treatment is when it gets a little bit higher at 0.50. But as you can see through 2018 through 2022, the majority are in the susceptibility range. And even before the alert, about 90%, I think it was 99.6% are susceptible to ceftriaxone. Unfortunately, there is an emerging mosaic allele called the PEN A60 allele that is showing some reduced susceptibility to cephalosporins and may increase the risk for treatment failure. It was first identified in Japan in 2016, and then in China, Canada, Europe, and Australia. Majority of cases were involving pharyngeal infections because antibiotics have poor penetration into the pharynx. And then in November of 2019, the first case in Nevada was discovered. And just last year, there were 2 cases in Massachusetts highlighting this PEN A60 allele. Because of that decreased penetration of antibiotics into the pharynx and for throat gonorrhea, guidelines for the 2021 STI treatment is ceftriaxone 500 milligrams, where it was previously 250 milligrams. And then there is a weight limit here. So folks that are less than 150 kilograms can get ceftriaxone 500 milligrams, whereas folks that are over 150 kilograms can get a higher dose of 1 gram. Again, chlamydia has not been excluded, adding on doxycycline for patients. This is just reviewing those 2021 updates. Again, increasing the ceftriaxone dose to have better pharyngeal coverage. We're no longer using dual coverage with ceftriaxone and azithro, so we're stopping the azithromycin. We're doing a test of cure for all patients with pharyngeal gonorrhea, because those are the cases showing reduced efficacy. And then retesting patients for gonorrhea in 3 months. As far as alternative options, you can see on the left, cefixime, an oral dose of 800 milligrams. If someone has a cephalosporin allergy, then we can use gentamicin plus azithromycin at a higher dose, 2 grams. But keeping in mind that there's no reliable alternative treatment for pharyngeal gonorrhea. It is still recommended to use ceftriaxone 500 if you're less than 150 kilograms. And of course, on the right, making sure chlamydia is also ruled out or treated. Now, if you suspect someone is failing treatment for gonorrhea because of resistance or maybe carrying that PEN A60 allele, there is a certain criteria that needs to be met on the left. So patients with persistent symptoms, more than 3 days, and no sexual contact, and other infections have been excluded, or you have patients with a positive test of cure, but reporting no sexual contact, or patients that have a positive test of cure that are showing MIC, so that reduced susceptibility, that is greater than 0.125, or for cefixime, greater than or equal to 0.25. And on the right, with the link at the bottom here, is this guideline that CAPTC and CDPH put out to kind of walk you through and evaluate this. And then, of course, we have our own webpage and resources. If you have any concerns that do come up about treatment failure or resistance, you can easily email us at STD Control Branch _ARGC. And then, of course, the provider resources, DIS resources for patients, and then local health departments as well. Overall, some takeaways and follow-ups. Test of cure for pharyngeal gonorrhea. You want to do a test of cure for chlamydia in pregnancy. And if you're using alternative regimens for LGV, then you want to do a test of cure as well. Be concerned with nucleic acid amplification tests less than 2 to 3 weeks when you're doing test of cures, because you might pick up some dead or non-viable organisms, so dead gonorrhea, dead chlamydia, which may not be actually showing a new infection, but just not eradication of the remaining DNA. Going to provide presumptive treatment of all sexual partners within the preceding 60 days, which then considers the use of expedited partner therapy, so cefixime for gonorrhea, doxycycline for chlamydia. Abstaining from sex until the regimen is completed and then symptoms have resolved. Make sure folks are returning for 3-month testing for routine, and then screening for other STIs, including syphilis and HIV, and maybe providing preventative care, doxy-PEP, HIV PrEP, which then kind of leads on to other preventative stuff, which I touched base on. That's that routine repeat screening, timely treatment, so every 3 months, maybe reducing sex partners, doxycycline post-exposure prophylaxis. I'll have a few slides of that. The expedited partner therapy, which I mentioned. Vaccines, instead of other preventive vaccines like HPV, hepatitis B, there has been some research showing that the 4C-Men-B, or Bexsero brand name, has shown some prevention of gonorrhea. The UK has included this vaccine and recommendations for men who have sex with men and transgender women who have been diagnosed with gonorrhea. And then notifying sex partners, and that can be done anonymously through tellyourpartner.org. As far as DoxyPEP, I do have a link here to CDPH guidelines that were put out. Also a CAPTC webinar that was done by Stephanie Cohen. And then word on the street is some future DoxyPEP webinars will be hosted by CAPTC in the future. So keep your eyes peeled for that. On the left, CDC recommendations for DoxyPEP that just came out in June of last month. And then I noticed that just yesterday, NCSD is doing a webinar on an overview of CDC's guidelines for DoxyPEP. That's the webinar registration link there, or you can Google that as well. And then as a final note, I think for your trivia nights at your local restaurant or bar, who else can get chlamydia? Well, the Australian koala can, although it is a different subspecies. So it's Chlamydia pecorum and pneumoniae. The complexity here, if you find interesting, is koalas do rely on bacterial fermentation. So if you're treating chlamydia with antibiotics, you might kill off the other bacteria, the good bacteria that is required for fermentation of the eucalyptus, and then they end up starving to death. And then koalas also possess very efficient metabolic pathways that do break down antibiotics as well. So it's difficult to give them certain antibiotics. And so one thing to think about for koalas is vaccination, which I thought this was all very interesting and fun to share. And with that, saying thank you. You can get my information from Kelly or Google it. And then, of course, acknowledgements to all my other folks that contributed to my slides.
Wonderful. Thank you, Dr. Moore, and thank you all in the audience for bearing with us. I realize we had some audio difficulties. Thank you all for pointing those out, and we will do our best to avoid those in the future. In terms of questions, we actually have a lot of them. Dr. Moore, I'm going to ask you to come back on camera and be part of this discussion so we can answer questions for the next 15 minutes or so. The first one is, to me, somebody helpfully pointed out in the chat that I was meant to discuss the importance of testing patients with syphilis for HIV. And I really want to emphasize that point. It's a great point. It's an important point. If you diagnose somebody with syphilis, they are certainly vulnerable to all other STIs, very much including HIV. So if you have somebody with syphilis and you've not already screened them for HIV, particularly in pregnancy, but not exclusive to pregnancy, I would certainly recommend screening them for HIV. Thanks for bringing that up. We're just kind of going to go back and forth a little bit now. So I'm going to bounce around. I'll do DGI next. This is a question for you, Dr. Moore. How often are you seeing DGI?
So we do track that. We do have epidemiologists that scan the data when it's reportable for gonorrhea, and then we look at medical records. I don't know if I don't have the stats in front of me. I should have prepared some of those stats that we have. You know, sometimes we can go weeks without seeing anything, and then sometimes we can have 3 or 4 cases in a week. I don't know, Kelly, if you remember any of the actual numbers or anything.
Yeah, it's a great question. So I can speak first as a clinician. As a clinician, I do general ID. I work in inpatient settings. I've seen a handful of DGI cases. I've not seen a ton of cases. So I wouldn't say it's common, but I would say that since July of 2020, California as a state has been actively surveilling for DGI, and we've seen hundreds of cases, and I think at this point it's 7 or 8, I think it's 8 deaths related to DGI. So hundreds of cases, some deaths, definitely something to be on the lookout for. And yet another reason STIs are really important to know about, to screen for, to prevent, to diagnose, to treat, because they can actually have some of these really severe manifestations, including morbidity and including even mortality. It's a good question. Okay, let's go back to syphilis for a second. Question is, do you still have to check an RPR prior to treatment if you're treating syphilis infection within 1 to 2 weeks? I would say very strongly the answer is yes. You do need to check an RPR on the day of treatment, even if it's only been a week or two since the diagnosis. And the rationale for that is that after somebody acquires syphilis, in those early phases in particular, the RPR can be on a very steep slope of rise. And again, you really want to know where that peak is so that you don't confuse yourself later when you're trying to monitor titers and you're looking for a fourfold decline to say, okay, great, this patient was treated and they did not get a reinfection. Again, you really, really want that peak titer on the day of treatment. Thank you for the question. Here's a hard one, also syphilis related. For pregnant people with late latent infection who are getting bicillin intramuscularly, 3 injections, 3 weeks, how much wiggle room do we have with the treatment at 7 days? This is an area of controversy. Like, what are the appropriate treatment intervals for somebody getting treatment for syphilis of late latent or unknown duration? So 7 days is ideal. The more you can stick to 7 days, the better. Pharmacologic considerations suggest that in non-pregnant people, 7 to 9 days are probably okay. And we think there's probably a 24-hour wiggle room. So if you're in California for non-pregnant people considers 6 to 10 day intervals to be acceptable for non-pregnant people again. In pregnancy, we really, really encourage 7 days and allow 6 to 8 days to be considered adequate treatment between injections. And we do have, actually, California Department of Public Health has some documents related to that. So we don't have them offhand to link to you, but I will put my email in the chat. And if you email me, which you should feel free to do, I will happily send you any resources that we mentioned that don't show up in our slides. Okay, this one's for you, Dr. Moore. Are you offering pharyngeal gonorrhea and chlamydia screening for non-MSM clients? So let's say men who have sex with women. Are you screening them at the pharyngeal site for gonorrhea and chlamydia?
I think this is definitely that patient-provider discussion. I think when I'm in clinical practice, it's taking a sexual history and talking about what their exposures and their risks are. And so after that discussion, if together we feel that there is risk there and treatment is reasonable, then yes, I have offered it to non-MSM.
Yeah, I think what you're saying is kind of on a case-by-case basis, correct? Yeah, the CDC doesn't formally recommend gonorrhea, chlamydia screening in that way for heterosexual men who have sex with women. But I think if you had somebody who was quite vulnerable to STIs, having a lot of sex, maybe even had prior STIs, it's reasonable to offer that screening, again, on a case-by-case basis. Okay. Somebody commenting on the koala, poor koala. All right, another one for you, Dr. Moore. With penicillin or cephalosporin allergy, is monotherapy for gonorrhea chlamydia with doxycycline an appropriate treatment, or would you still add? So I think we can break that question up. You're muted by Dr. Moore.
Yeah.
Please unmute.
So cephalosporin
so
allergy?
For chlamydia, if somebody, let's start with chlamydia, cephalosporin allergy. Doxycycline's fine, right?
Yep.
Not an allergy that would affect chlamydia.
Yeah.
Yeah. For gonorrhea, monotherapy.
With
if you couldn't give
doxycycline by itself?
If you needed to treat gonorrhea. Yes, that's the question.
Well, monotherapy. I mean, maybe you get a.
Yeah, I would say for gonorrhea, for people with allergies to penicillin or cephalosporins for gonorrhea, there are guidelines of what you should do, and it's typically azithromycin and gentamicin is your option for gonorrhea. But chlamydia, it's fine. Use doxycycline 7 days, correct?
Yes, I would agree.
Okay. Wonderful. Sorry, I'm just scanning through questions. Awesome. Okay, here's a good one for you, Dr. Moore. It's about LGV. wondering if you can talk about LGV a little bit more and when a provider might want to suspect LGV in the context of a positive rectal chlamydia test.
Yeah, great question. I think the times that I've seen it in clinic, it was more symptom based. So the patient is presenting with painful bowel movements, feeling the need to evacuate, discharge, not always bloody, but can be bloody, just painful, feeling very uncomfortable. Um, and so using symptoms as that guidance when to think of LGV. And if I was in a scenario to treat them with the doxycycline and maybe order the LGV test, the molecular test as well at the same time because I have a high clinical suspicion, so then I can extend it. Or it might just clinically feel like you're having a lot of symptoms. This sounds more like LGV versus just chlamydia by itself, or it's normal, not really normal, but the non-serovar LGV type, and then give them a 21-day prescription of doxycycline.
Great. So essentially, if somebody had really severe rectal symptoms, proctitis is one of the most common syndromes. So like you're saying, really severe rectal syndromes might be thinking about LGV and just extending that doxy course to 21 days for LGV coverage. Okay, question for me. What are some non-serum tests for syphilis? The reality is in most places there are not non-serum tests for syphilis, and most places are going to be reliant on serologic testing for syphilis. I wish this was not the case. I wish I could tell you we had different or better diagnostics. I hope we will one day, but for most places, serum is what you're going to have available. There are a few sites in California that have a dark field microscope, which is a special type of microscope that can be used to basically you sample a lesion, you put it on a slide, you look at it in this special type of microscope, and you can diagnose syphilis that way if you see treponemes. And then there are a few research settings starting to play around with different syphilis PCRs in different contexts, but again, not widely available. So again, for most of you all, you're going to be stuck with serologies, at least for the time being. And I do hope that changes in the future. Okay, back to you, Dr. Moore. A couple of folks are in the Q&A asking about vaccines that prevent STIs, and particularly about HPV and the age cutoff, where now you can offer it to folks up to age somewhere in the 40s. What do you think about that? Can you speak to it more, particularly in the context of head and neck cancers and that sort of thing? What do you think about extended age HPV vaccination?
Yeah, I think I've worked in places that are pretty liberal with HPV vaccine, and even with folks that are getting diagnosed with HPV, even the ones that are covered in the vaccine, providers are giving that vaccine because of the high risk, and maybe they don't have all the HPV types that are covered in the vaccine. And so this definitely, it's recommended through age 26, and then maybe through age 45 on that kind of patient-provider discussion. I doubt that there's many harms with it. I think there's definitely costs that go along with it to the healthcare system. I myself practice pretty liberally. If someone's asking for it and they're less than 45, I will give it to them. But I just think I'm just vaccinating everybody.
All right, fair enough. Thank you so much. Okay, another question for you, and then we'll come back to me. If a patient is positive for gonorrhea of the throat, so pharyngeal gonorrhea, when do you recommend a test of cure?
Yeah, great question. So CDC says 7 to 14 days, but I think there's some reasonable suspicion that anything less than 14 days might pick up kind of that dead gonorrhea DNA, and you might have a false positive in that time frame. And so some guidance says at least 2 weeks before you retest, but CDC does say 7 to 14 days.
Yeah, agree. I think, yes, CDC, like you're saying, so 7 to 14 days. If it's me and I'm offering you advice, I would agree with Dr. Moore and try to stick with the 14-day mark just because we see residual genetic material from dead organisms when you test earlier, and then it's very confusing to end up just having to test again anyways. So I recommend sticking to the 14 days for test of cure pharyngeal gonorrhea. Okay, so syphilis question for me. Any reason why a clinician might favor serum testing, like through a blood draw, as opposed to rapid testing for syphilis screening? Yeah, I definitely think so. The rapid tests, they only detect treponemal antibodies. So if somebody has a history of syphilis, if they've been treated in the past, that's just going to be positive over and over again. So it's not helpful in that setting. Where I see point of care testing being the most useful is in places where you're maybe not going to reach the patient again. You think they're very vulnerable. If what you would do is like on the basis of a prelim rapid positive test, I'm just going to treat this patient because they're pregnant. I'm not going to see them again. They're in correctional setting and they're about to be released and I'm never going to see them again. Like if you're going to act on a rapid test, then I think that would be the time to get it. Otherwise, the serum testing is still, to my mind, if it's 6 of one, half dozen of the other for the patient, I would recommend getting the blood draw, the serum testing, because then you're going to get a non-treponemal result. You're going to get a titer. You're going to have something to follow. So that's how I would be thinking about that. It's a great question. All right, I think we have time for at least one more question. This one's also about syphilis, and it's a hard one, and it's one where there's controversy. So this person is asking if somebody gets 14 days of IV penicillin for neurosyphilis, but they also have syphilis of late, latent, or unknown duration, do they need additional bicillin after the 14 days of IV penicillin treatment? This is a very controversial topic. I will tell you, there are definitely experts, including some notable ones at Johns Hopkins, including some folks at University of Washington, who do not give any additional bicillin, who believe that the 14 days of IV penicillin is sufficient. It's a high dose, you're penetrating the CSF space, you're good, you don't need to do anything else. So people will tell you that, and I think at this point, there are reasons that might be what clinicians choose to do, and you're definitely in good company if you choose to only do the 14 days of IV therapy. There are others, and for now I'm included in this camp, who just don't quite see the logic of that approach. And the reason is because if you read about late latent syphilis or unknown duration syphilis, what you read is that you have to sustain penicillin levels and you have to do it for at least 21 days because in latent infections, the treponines are dividing very slowly. And so you have to keep hitting them for 21 days. So for me right now, I still like to get to the 21 days of penicillin coverage. So if I give someone 14 days of IV therapy, on that last day, I do like to give them a dose of IM bicillin, which covers them for 7 more days, getting us to 21 days. This is based on logic. There's actually not clinical or lab data really to support one approach or the other. It's a wonderful question. And like I said, you would be in good company really if you picked either approach. And I think we have come to the end of our Q&A and also the end of our questions. So I hope we addressed all of your questions. Thank you, thank you, thank you to you all for being here. I hope you'll join us on our next webinar or in-person event. Thanks so much. Bye.